welcome. It's a great privilege to serve as the moderator for this program, and we have some great speakers I'll be introducing, and I just want to give a little overview start. Want to thank the American Brain Tumor Association and some of the Peer Review Institute sponsors, Bayer, Novacure, for making this possible. Today we're going to look at some of the opportunities for improved outcomes in glioblastoma. And I'm going to present some of the issues that we have. And Jeyapalan is going to talk about tumor treating fields and its potential impact in improving outcomes. And Ahluwalia is going to talk about the landscape in immuno-oncology and targeted tumor therapy. So can I have the first slide? Just some housekeeping notes. If you haven't already, please complete the pre-event survey. And a reminder, look out for additional follow-up polling during the presentation. And submit your questions. We already have some, and we'll answer them during the Q&A. We also have this URL website. You can view all the slides and then practice aids. There's a lot of additional material after the event. So if we look at glioblastoma, we look at the 5-year relative survival. Obviously, the upper left, it is linked to age. Treatment goals are both systemic and local. Local, we know surgery, radiation, stereotactic radiosurgery, and tumor treating fields are designed to prevent the recurrence, which is almost inevitable, and which 80 to 90% of the time is in the same site, surgical resection bed. The ultimate control is chemotherapy, biological therapy, immunotherapy, and I may have a few moments at the end to discuss a trial that was just published today, and targeted therapy. Glioblastoma presents extraordinary challenges due to this localization of tumors in the brain, and the seminar this morning in the educational section showed the intimate relationship of the glia, the neurons, and the difficulty of the problems presented by the invasion and infiltration within the brain. There's also well-known problems of angiogenesis, disruption of capillaries, leakage, and edema, as well as the limited capacity of the brain to repair itself and the concerns of neurotoxicity, as well as many escape mechanisms, stem cells, and so on. So it's quite a formidable challenge. In terms of, there's also a disconnect between laboratory and the clinic and full application of all of the weapons we have. So tumor treating fields, for example, was FDA approved 11 years ago, and by many considered standard of care, yet it's low penetration in the clinic, between 3 and 12% of those with newly diagnosed, and about 10% of those with recurrent disease are given this treatment. And so soon Dr. Jeyapalan will discuss that problem in detail. And Dr. Ahluwalia, who is real authority on clinical trials, will discuss practice guidelines as they are recommended. And we now know there's a clinical trial effect, that just by being on a clinical trial itself, even if the agent ultimately is proved to be ineffective, just by being on a clinical trial can increase survival. Despite that, fewer than 11% of patients with glioblastoma are on clinical trials. And we're going to begin this session with the American Brain Tumor Association's introduction of a patient named Eric, who's describing what it was like to learn that he had glioblastoma. We're trying to make that day when you find out you have a glioblastoma not the worst day of your life, but a day full of hope. So will you roll the movie?
Thank you, Peerview, for inviting the American Brain Tumor Association to participate in this impactful program once again this year. My name is Umbreen Maan, Program Manager at the ABTA, and today I have with me Eric, who will be sharing his experience and insight as a brain tumor patient. Thank you so much for joining us today, Eric. To get us started, can you tell me a little bit more about your diagnosis and what it was like hearing for the first time that you have a brain tumor?
April of 2020, we learned that there was a brain tumor, and we had to find a hospital that still had capacity to perform urgent surgery that was able to do a craniotomy. The first real knowledge that this was glioblastoma occurred when we had an in-person meeting with the surgeon a few weeks after the surgery. And by then, pathology came back with glioblastoma and with all the markers, which really did not sink into my head at that time at all. And we were advised that it was a life-shortening situation, and he did not really delve into the mortality rates, just leaving it that we could be looking at something as short as 5 years. It wasn't later that we learned that statistically it was in a single-digit percentage that made it to 5 years. So how did all this impact us was actually it was as good as it could be expected because it was given to us in increments instead of all at once. But it wasn't spread out over an over long period of time. It was given to us as we could handle it. But that phrase life shortening was very helpful to help me, help my wife start processing the significance of this lightning strike that just hit us.
Pleasure to introduce Dr. Jeyapalan, who is the director of the brain tumor program at Tufts. Go ahead.
Hello, it's a pleasure to be here today and talk to all of you about this treatment about basically integrating innovative multimodal approaches into glioblastoma care. So I'm going to try and give you the latest evidence and guidelines for tumor treating fields. Let's see here. So I'd like to start off with the survival curves, all right? This is from Damatu Bahar, and she was a neuropathologist at the Mayo Clinic, and this is from 1988. And this is the survival that all of our patients will have with radiation and surgery. So if you just do radiation and surgery, your 2-year survival is going to be about 5%, and your 5-year survival is going to be basically 0. And I even saw a question right now that popped up on our question list, is why have we impacted the survival so little in 50 years? And I'm going to say that is a complete fallacy and unfortunately a misunderstanding of what we actually have done. And there's actually been huge improvements of both the 2-year and 5-year survival curves, and I'm going to discuss this with the next thing, but keep your eye on this, keep this in your memory, this survival curve. This, everyone in the room is very familiar with. This is the enemy, right? You got this large left temporal, centrally necrotic. This is the part of the tumor that's outstripped its blood supply and is dead. And then you have the advancing rim of the tumor, which is the contrast enhancement. But we all know that this is just the tip of the iceberg. If you look at the FLAIR imaging, the tumor is already invaded through the entire left hemisphere, and it's starting to cross over into the right. In the 1950s, before there was IRBs, the neurosurgeons would biopsy the other side of the brain, and we'd find glioma cells on the other side of the brain. So the time of diagnosis, this disease is throughout the brain. The horse is already out of the barn, running away, and we're trying to drag it back in and get it under control. And that is our challenge, and that's why the survival curves basically looked the way it did in the 80s. the gentleman, the doctor that ran the 4-minute mile, really, in neuro-oncology is Roger Stoop, and this was published in 2005, and it has become the standard of care throughout the world, that where he added on temozolomide, as you all know, which is an alkylating agent, and it's supposed to enhance the effect of radiation, and then he gave it in the adjuvant setting for 6 months, and for the first time, you saw this doubling of the 2-year survival, up to about 25%, and then we had 5-year patients that lived out 5 years or more, and that had never been seen before. So the survival curves have now been moved forward. His second, so you can call it STUP 2.0, STUP squared, his second follow-up trial, which was actually in 2015, was looking at tumor treating fields. Tumor treating fields actually goes back many years. They have both in vivo and in vitro data going back to the 1990s. In 2004, they did the first pilot trial in humans. Then they did the recurrent GBM trial, which they received FDA approval for. In 2015, they did the newly diagnosed GBM trial, which they also obtained FDA approval for. And then they went to systemic cancers. They're not sitting on their laurels. And they got FDA approval for mesothelioma. And now they have many trials going on in different other solid tumors systemically. The results in CNS disease led in 2018 to a Category 1 designation by the NCCN, the National Cancer Comprehensive Network, where based on the 5-year survivals, it is now recommended for both methylated or unmethylated patients in combination with standard radiation as well as concurrent temozolomide. And not only is it recommended for that patient population, but as I tell all my residents, my fellows, and my other trainees, don't be an ageist, because this was actually shown to work in patients over the age of 70 as well. So I always try and gear the treatment to the patient. If somebody it looks good and looks like they can tolerate treatment, then definitely offer them everything that can help them. So I'm going to introduce you now to tumor treating fields, because people always come up to me, even now that it's been FDA approved since 2015 and it's 7 years later, people are still somewhat confused as to the mechanism of action. So you have to go back to basically your high school biology, and this is what I tell patients. Remember mitosis, right? And what happens in mitosis, DNA has doubled, the microtubule spindles have formed, they drag DNA to the center of the cell, the cleavage it forms, the cell divides into two, and the daughter cells take half the amount of DNA into them, and therefore you get replication. With an alternating electrical field, what you have is all proteins have a charge, as you know. The alternating electrical field basically acts on these proteins, and they just basically are not able to move very well in the cell as they're getting dragged in either direction. The microtubules do not form. The DNA does not get brought to the center of the cell. The cleavage formation also doesn't happen because that's protein mediated. The cell does not divide into two. There's a double dose of DNA in the cell. That is a lethal event for the cell, so the cell undergoes apoptosis and then dies. And why was this started off in the brain first? Because if you remember, and we all know this as neurologists or people who treat patients with brain disease, is that everything in the cell is in G0, the resting state. Nothing should be undergoing division, so this was a very targeted therapy for the brain. And this is one of the reasons that they went forward with the trial first in the brain. The only cells that die are the ones that are attempting to undergo mitosis and divide. However, this is an electrical field, right? And you can tune the electrical field based on voltage, you can tune it based on frequency, and it was seen that when they looked at cell kill in vitro studies, that the effects on the cells are frequency specific, all right? And inversely related to cell size. So a glioblastoma tends to be a smaller cell, so it needed a higher frequency of cell kill, about 200 kilohertz. Non-small cell lung cancer and breast cancer and pancreatic cancer are slightly bigger, so they need a slightly lower frequency of cell kill. But the normal intestine, its cell kill is more at 50 kilohertz. So you can understand, then, therefore, you can treat systemic disease and specifically target the cells, the cancer cells, with protecting the normal tissue. And that is how the company has moved into trials with using the device in systemic cancer too as well. So this is what it looks like. So I've heard many myths about this device. Oh, it weighs 30 pounds. Oh, it weighs 8 pounds. It never weighed any of those. In the original trial, it weighed about 6 pounds. Now we have version 2.0, basically weighs about 2.5 pounds. So I tell my patients, you've basically moved from your Dell laptop to your MacBook Air. And that's what you're carrying around. I tell ladies, if you think about what you're carrying around in your purse, it's probably much heavier than this actual device. And this is what it is. So the patients wear their rays. The rays are made by 3M, the company. They wear them front, back, and right, left. There are 9 ceramic electrodes that are embedded in a conductive jelly, and it's connected up to the device that it holds both the battery as well as the computer. And that computer tells us exactly, because it comes on and it records when the circuit is completed. So we know exactly how much the patient is using it, and we get reports every month. They're using it 50% of the time, 12 hours a day. They're using it 75% of the time, 18 hours a day. So even in the clinical trial, the company had very accurate assessment of how much people are actually using the device. And this is unlike when you think about pills that you give people in clinical trials, where you give them a bottle, you give them a calendar diary and tell them to record. Well, who knows how they're doing it and if they're recording it correctly. But in this case, we knew how they did it. The other thing that is possible with this is you can arrange the rays on the surface of the brain so it targets a quadrant of the brain. And as if all of you know, 90% of the time when a GBM, a glioblastoma comes back, it comes back within 2 centimeters of the resection cavity. So this is an area of high risk, and you can target the array to treat that area of high risk. And we now have post-hoc analysis, which I will discuss later in my presentation, that confirm that the areas that got the higher dose, actually you saw tumor regression. And I will discuss that in a couple of slides. So before we move on, I'd like you to take a moment to answer a follow-up poll on the tumor treating fields. And this is going to be on your iPad and virtually. All right. So now I'm going to discuss clinical data in newly diagnosed GBMs. So this is the EF14 trial. It was a very simple 2-to-1 randomization. There's again a lot of mythology that happened with this trial, but I'm going to try and explain it to you. Everybody got the standard strip regimen. They did their 6 weeks of radiation combined with temozolomide. They did not want to combine the tumor treating fields with radiation because they weren't sure what the interaction would be. So they actually then randomized people to start after radiation. And about 450 people got the device, and about 250 people got the standard of care. And then they went on to the first progression, and if they had a progression, they were allowed to continue on the tumor treating fields to a second progression, and that is because they knew from the recurrent GBM trial, the median time to response to the device is about 7 to 8 months. Some patients are early progressors, and they did not wish to take away the device that before it had time to have an effect. In the standard of care arm, they were allowed to go on to the physician's best choice of second-line treatment. The inclusion-exclusion criteria were standard. They were patients over the age of 18. There was no age gap, so in the original strip trial with temozolomide, it was 18 to 70. Here, patients over the age of 70 were allowed to participate. They had to have had they've had to have radiation already with maximal debulking surgery with, temozolomide too as well. They had to have a good performance status. Exclusion criteria, anything that would prevent people from having continuing maintenance temozolomide, such as decrease in blood counts or impaired liver or renal function. They also excluded infratentorial tumor because the front part of the ray would have to go over the mouth. And at the time, the company had not worked out the physics of being able to target the brainstem. In 2018, a white paper came out that showed how we can arrange the rays so that we can target the brainstem too as well. So that is now a possibility. So this is the results. This was the progression-free survival in the intention to treat population. You can see it was a highly significant p-value with a hazard ratio reduction to 0.63 and with about a 3-month improvement of median survival. And this is the overall survival where you can see, now look, remember those Demaux-Duport curves. Remember, it was 5% at 2 years. Now we're up to 43%. It was a 50% approval of temozolomide alone, and it tripled the 5-year survival towards up to 13%. And if you remember the Demaux-Duport curves, there was really nobody alive at 5 years. So this was, again, a highly significant p-value, hazard ratio reduction to 0.63. Roger Stoop likes to say that this is, likes to point out this is the same hazard ratio reduction that temozolomide had in his original trial, and a 5-month improvement of overall survival. So big gains. This was just recently published in 2022, so I just wanted to bring this up. This was the commercial experience that confirmed that there was, in the commercial use, there appears to be a 45% improvement of overall survival, again, with a very significant P. There was a subgroup analysis for overall survival that I'd like to talk with you, because when I presented the data back in 2015 at our neurosciences grand rounds, our chair of neurosurgery says, Surya, this is a very low energy device. And I think when you guys do your post hoc analysis of this study, you're going to find that it's going to be the gross total resection patients that are going to do the best, because they're only going to have microscopic disease left behind. And I think that this device is going to help keep those quiescent cells quiescent. But I can't see how a low energy device can help patients that are biopsy only and have this raging GBM, that the horse is already out of the barn and we're trying to get him back in to the barn. And I just can't see how that's going to help. Well, lo and behold, when you look at the effect size with the hazard ratio reduction, the people that actually had the best were the biopsy only in this. And that's because they did so badly with just the temozolomide alone. They still don't live as long as the gross total resection, but they respond to the treatment so well that it really helps their hazard ratio and it really improves their survival too as well. The same thing with the older people. As you can see, almost 20% of the patients were older. And there, look at their hazard ratio reductions. It's incredible, much more than the younger patients too. But again, it's because just giving them temozolomide alone is not enough. And what I like to I hope you take away from this is that we build on what we've had before. We shouldn't, expect to hit a home run with one agent, but we can combine therapies that are well tolerated and then add to them and improve those Demaux-Duport curves even better. The other thing to add in is sort of an internal control. It shouldn't matter if you're a man or woman, and it didn't. Both, had the same effect. And it shouldn't matter if you're unmethylated or methylated in this trial, because it's not dependent on MGMT methylation at all to have its effect, because it's an antimitotic agent. So you can see that that didn't matter either. And then as we move forward, I wanted to just talk about quality of life. It is, people talk about this device, and they don't think about it in terms of survival, but they say, well, what about quality of life? Do patients actually tolerate doing this, shaving their head twice a week to wear this device, carry around a 2.5-pound device around? And so the company actually asked quality of life questionnaires and measures, and they recorded them from not only the patient, but their healthcare provider, their spouse, their child, their loved one that was helping them through this. And lo and behold, it was no different than the patients that got temozolomide. So that's something to realize. The other other thing that was very important, and when you're talking to your patients, compliance was essential. This is electricity, right? If we turn off the switch, we flip that switch in this room, lights are out. There's no half-life. Nothing hangs around. So I don't know if some of you in the audience have electrical cars. It takes a little bit to get used to, right? You left your foot off the accelerator, the car just stops, right? There's no coasting like in the internal combustion engine. Similarly here, there's no half-life. You have to use it for it to work. And they show an independent prognosticator was that if you used it 75% of the time or more, it was a significant reduction in the hazard ratio. Also, if you use something, the more you use it, the more it will work. So here's your dose response curve, right? So if you give people, tell 450 patients to use something 75% of the time for 2 years, they're going to get a variation. And when you look, if you did not use it at least 50% of the time or 12 hours a day, it does not work. You may as well not use it. And remember, when you're using this in the commercial setting, when you're talking to your patients, you know how much they're using. You have to encourage them to use it more. But what you can also see, that the patients that used it 90% of the time or more, which was 45 of the patients, they had a marked improvement of their hazard ratio reduction compared to the people using it 50. So it's a dose response curve. What was interesting in this, and this was presented at SNO several years ago, was that those patients that use it 90% or more, their 3-year survival was 30%, their 4-year survival was 30%, their 5-year. They had this flattening of their survival curve, where clearly there's a subgroup of patients that keep on coasting using the device, and I've seen that in my own practice, and we had opened up the trial, so we have patients that have had this extended survival. So that's something to think about too as well. Another point that we were talking about is targeting it. If you target the rays so that the intensity and the power of the rays are directed towards the resection cavity, because remember, 90% of the time the tumor recurs within 2 centimeters of the resection cavity, we now have the post-hoc analysis that showed that targeting will help local control. And this was, again, published just recently in the Red Journal, where it shows that when you had a dose that it was higher in the areas of the tumor that regressed, whereas when the tumor did come back, it was where the field was not as intense. And so we have that post-hoc analysis too, so people can take a look at that. So all of this then comes together to 5 key principles. We know we can target specifically cancer cells and spare normal cells by dialing the frequency, and higher frequency small cancer cells, and then lower frequency large cancer cells, with realizing that the normal intestine is very low and can be protected because it's not sensitive at the higher frequencies. We also know we can adjust the intensity of the field by directing the rays towards the tumor, and that the power is also very important in that sort of situation. But the compliance, if they're not wearing it, it's not going to work. There is no half-life. And when they combine the dose density, which is basically power and compliance, there was continual improvement of survival. And this is something we all need to talk about with our patients. This makes sense. This was proven. This is what you need to do to improve your survival. So finally, I just want to talk a little bit about a case. So I like this because this addresses a couple points. One, this was a woman. Everybody says, oh, women don't want to shave their head. Number 2, oh, older people, you might as well just give up. And number 3, there are challenges in treatments of patients up front, but that doesn't mean that they can't overcome those challenges and have a meaningful long-term survival. So this was a woman. She had a left temporal mass. She underwent a craniotomy with gross total resection of the mass. She was IDH wild type, but she was MGMT methylated. She had a good performance status immediately after surgery. We gave her the 6 weeks of chemoradiation. We did have to stop temozolomide in the 5th week due to thrombocytopenia, and she struggled with that a bit. We did try adjuvant temozolomide with tumor treating fields, and she has the Waldenstrom, so that was contributing to her pancytopenia. So we then did the dose-dense temozolomide, which was the Canadian rescue regimen that Dr. Perry had published in JCO some years back. And she was able to complete about a year of temozolomide. And now she's done monotherapy for about 57 months now, almost 5 years out of her original diagnosis, without any evidence of recurrence of disease. And just as a funny thing, like when she was struggling there in the beginning, she took the whole family to Orlando. She paid for it, and they had a great time. They came back. You know, she was actually in a wheelchair at that time. A year later, her scan looked great, and it continues to look great. And the family was like, "Oh, let's go down to Florida again." And she was like, "What? I'm not paying to take the whole lot of you to Florida again. I thought I was dying. I need to hang on to my money, you know." So this is just the thing, you know, people can struggle in the beginning, but they can still do well. And then talking about some of the strategies for the dermatological side effects. So this is a paper I like to direct everyone to. It's by Mario Lacoutre. It's in Frontiers of Oncology. It's in 2020. And he's a dermatologist oncologist at Memorial Sloan Kettering. And he really has looked at this very well and looked at what are the issues that prevent the compliance with the device. So sweating, Florida, I'm sure the people here know that these patients, you know, they have a hard time going outside. So interestingly, using like a roll-on antiperspirant gel, after they shave their head, let it dry, you roll it on, it fills up the pores, and that helps decrease that. And you want to use about a antiperspirant that has about 12 to 20% aluminum chloride in it. Itching is another one. That's inflammation, so you can use a topical corticosteroid. So we use clobetasol, which is like a solution lotion. You can help them with GABA agonists or antihistamines to help with that too as well. Patients occasionally will get some ulcers and erosions, so you can just make sure they're fitting the device well. They can move the rays away from the areas that'll heal them up. But sometimes they'll get a secondary infection and a folliculitis, so you can just give some clindamycin lotion. You do have to stay away from creams and things with petroleum-containing products in them because they will impede the effect of the rays, and that's been shown. So you do have to be careful what you recommend, and so follow that paper, and they give some good recommendations. So now we'll go back on to Eric, who will talk about some of those issues that, you know, that patients have with accepting the glioblastoma as well as the treatment.
So I know you said you've been on the tumor treating field now for 2.5 years, is that right?
Yep.
What has it been like for you? What's your experience been like with the tumor treating field?
It wasn't always easy. This very same backpack that I use now so easily was so difficult for me to manage at the beginning. But humans are kind of plastic, right? We're malleable. We can acclimate, we can overcome, we can adapt, we can do it. One of the most powerful points was the effectiveness chart that has been shared with me or I found somewhere that says it is most effective when you can maintain the tumor treatment field for 90% of the time or more in a month-long period. But it's still effective when you're less than that. And you know, that got my competitive juices going. We're going to go there. And so my first handful of months were at 96%. And then they kind of worked their way down to 93%, where they usually are around now. But that also gave me the comfort to take it all off so I wasn't upstaging my daughter when she got married, okay? Or to be, so I have a 6-hour break there. Or instead of changing the gear every 3 days, which is our pattern, maybe because of a vacation, we'll change them every day and take a 4 or 5 hour break in the morning so I can enjoy some stuff, and then we'll put the stuff on for the rest of the day. Some people talk about how it stops them from doing things, and there are things you just can't do with it. I get it, but I wonder how many people are just not willing to adapt to their new circumstances. And I think that's a great place for caregivers, counselors, and doctors to offer guidance in adapting to the new reality. It's not the mechanism of a TTF that is messing things up. It is the tumor that's messing things up. And we're trying to get as much life as we can despite the tumor.
So, you know, he talks about several patient concerns. So one is information overload. You know, you just have to make them understand that there's this learning curve while using it, and gradually they become adjusted to the device. Reluctance to shave their head. I think the 80-year-old woman showed people want that survival benefit, right? So you just have to validate it, help kind of normalize it, and tell them, you know, this is what's going to help you in the future. You know, patients always talk about this, about being a burden and not, or, you know, to their caregiver. And all I can say is I tell them, if you switch places, would you feel that your loved one is a burden on you? You don't. You want to help your loved one. I think they have to realize this is the time that their family can help them, where they've always helped their family in the past. But again, you know, sometimes maybe having a caregiver pool might also help them. And sometimes people just feel overwhelmed. Do I really have to wear it all the time? And then I think he talked about taking breaks. So in the original trial, they did allow a couple days off that people, if they wanted to go to a wedding, go to something, they wanted to go camping and they didn't want to use it, that was fine. You can kind of store it up because it was monthly usage. So if you kind of bank it up, what some of my patients do, and they get like 90%, and then they go off for a weekend and do something, you know, they know their percentages are going to be above 75% by the end of the month. So that's something that people can do. So before we move on to my last couple of slides, please take a moment to answer these 2 follow-up polls on the management of these patients with newly diagnosed glioblastoma. Okay. So this is going to be my final couple of slides. I just want to say some of the future directions we're doing with CNS disease, and we're trying to now look at the role of combining it with radiation. So Manesh Mehta, who is down in Florida, has this trial open for brain metastasis. It was a very natural, you know, progression from dealing with brain disease. So patients with lung cancer who have 2 to 10 newly diagnosed brain metastases that are amenable to stereotactic radiosurgery, half of them will go to the standard of care radiosurgery alone, or half of them have tumor treating fields given after the radiosurgery, with the idea being is that you want to prevent relapse in the brain from, you know, improving local control, but also improving any or decreasing the chance of distant relapse. So the primary endpoint was the time to intracranial progression. In July of 2021, an independent data monitoring committee reviewed the data and said that it could continue as planned, and we are expecting results in early 2024. And finally, this is the EF32 trial, which is ongoing in newly diagnosed GBMs. There were several phase 2 studies, 2 that were done in the United States, 1 in Israel, which combined tumor treating fields with radiation that showed safety, but also showed some early signs of efficacy. So this trial, all we're doing is we're moving the tumor treating fields up 3 to 4 months to start with radiation. And we're hoping to prevent these early relapses, help these patients that were going to relapse early by starting it earlier, so that the 7 to 8 months, you know, median time to response, we can capture some of those early progressors and hopefully get the device in to help them before. But what was also seen is that there's new mechanisms of actions that are being investigated about tumor treating fields, and it does seem to interfere with DNA damage repair, and it seems to interfere with DNA double-strand breaks, and that's been shown in vitro. And so when you look at this, you know, the mitosis, the 2 of them act in multiple different stages in the cancer cell's division cycle and have this kind of additive effect to help, you know, enhance cancer cell kill. And with that, I'm going to turn this over to Eric again, and that we'll watch a clip of Eric discussing the need to do clinical trials.
Can you share for the audience just some thoughts that you have on the value of clinical trials, the importance or the benefits that it might be able to provide either for you in the future or for patients in general?
Well, yeah, in general, I think they are necessary, and they are wonderful, and they are important. Having paid attention to a few over the course of this experience, and that's how the TTF field came into being, to be an FDA-approved standard treatment, was through clinical trials. And clinical trials can't work without patients willing to participate in them. there are degrees of awareness, both amongst the general population and amongst medical professionals. These awarenesses are not necessarily in line with the reality. And the ABTA is one vehicle to raise that awareness. And in terms of its work directly with patients and their support groups, it's a direct line. It's a direct line, and it's so important. But also, maybe the ABTA has a role in helping physicians and the medical teams remember and recognize that these patients with highly specialized and complicated medical needs, we're still human.
Great. Next, I have the great privilege to introduce our colleague, Dr. Mami Ahluwalia, who's going to talk about the current landscape in clinical trials in neuro-oncology.
Thank you so much, Dr. Brem, for the kind invitation to come and give this talk. And I would like to congratulate Dr. Jeyapalan for a very eloquent and excellent talk on the role of tumor treating fields, not only in glioblastoma, but emerging evidence in brain metastases, because several of us who treat patients with glioblastoma also take care of patients with brain metastases. So today I was tasked to speak about new and emerging systemic therapy options for glioblastoma, strategies for maximizing patient outcomes. And essentially I'm going to focus mostly on the data that is published, but also talk about some of the new opportunities that may lie. So before we go any further, as Dr. Jeyapalan had talked about, we have made tremendous progress, not as much as we would like, but still we have made a difference in the lives of our patients. Our patients are living longer. Despite that, we know glioblastoma, I always call it the last frontier, because despite our best efforts, most of our patients will recur. That means their glioblastoma that initially, if it responds to treatment, will come back, unfortunately, still on an average between 6 to 12 months based on their MGMT methylation status or what they've been treated with. And so this is the NCCN guidelines for patients who have recurrent glioblastoma. And as you can see, the preferred regimens include bevacizumab. You can always re-challenge temozolomide. Dr. Jeyapalan talked about a case with the metronomic dosing, which is often used in recurrent setting. We can use the alkylating agents like lomustine or carmustine. We still have the PCV regimen, which is procarbazine, lomustine, and vincristine. And you have the regorafenib regimen based on a trial from Spain that I'll talk about. Otherwise, you could use a combination of therapies, which include systemic agents combined with bevacizumab, and there are a number of them. None of them has actually been shown to be better than bevacizumab, though, or you can use combination of alkylating therapies along with bev, or sometimes people will use re-challenge of temozolomide with bev, or sometimes when patients progress on temozolomide, we are not sure whether they're progressing or a pseudo-progression. We try to continue with temozolomide and add bev. Now, in certain group of patients and circumstances, you can use etoposide or platinum-based regimens, although the categories of approval for these therapies is lower. But in some selected patients, you can use drugs like larotrectinib and entrectinib, which are approved for NTRK gene fusion tumors, which is very exciting based on pan-tumor agnostic approvals. And then more recently, we've had data come up in BRAF V600 activated mutated patients where BRAF and MEK inhibitors can be used, including dabrafenib and trametinib, or vemurafenib and cobimetinib. And I'll talk some of the data behind them. So this is a trial which was a phase 3 trial of bevacizumab plus lomustine. It was done by Wolfgang and Wick and colleagues from EORTC. Basically showed that there was no difference when you used a combination of lomustine and bevacizumab compared to lomustine. And essentially, all these patients who got either of these regimens in first recurrence of glioblastoma survived on an average of around 9 months. There was a slight improvement in progression-free survival with bevacizumab, which we know it's mostly an artifactual because bevacizumab is an anti-permeability agent targeting the vascular endothelial growth factor, and there is a improvement in progression-free survival. But as you can see, overlapping curves between lomustine in orange and lomustine and bev in blue. This was a trial that got a fair amount of press. This was a phase 2 regoma trial of regorafenib, which was a study done in Spain. And regorafenib is a multi-tyrosine kinase inhibitor, which basically targets the vascular endothelial growth factor, but it does target a number of other pathways, including c-KIT, PDGFR, amongst others. And here you can see there was improvement in both progression-free survival in the curve on the right, as well as overall survival. Lomustine treated patients had a survival of 5.6 months. Those who were treated with regorafenib got overall survival of 7.4 months. And you can see an impressive hazard ratio of 0.5. One of the critiques of this study was that the survival seen on lomustine arm of this study was slightly inferior to some of the other trials that have used lomustine in first recurrence. But this is, obviously a randomized trial which did show that there was a survival benefit with regorafenib in a randomized phase 2 setting compared to lomustine, and regorafenib has undergone evaluation through the GBM agile mechanism, and I'll talk to you about that in a few slides down. So before we move on, please take a moment to answer one follow-up question poll on your iPads on systemic therapy options for glioblastoma. So moving on, and studying glioblastoma, obviously, and as you heard Dr. Brem talk about, despite clinical trials actually being the #1 option, when you look at NCCN guidelines, glioblastoma is a tumor type where we actually say you prefer clinical trial treatment option for patients over standard of care. If you go to rest of the cancer or oncology, the recommendations are standard of care or clinical trials. So we are in a field where we really feel that every patient who's eligible and ready to go on a clinical trial should be on a clinical trial. So all of us who are clinical trialists working whether at academic centers or other centers, our primary focus is, can we have a trial for our patient, and can we offer that trial to our patients? And because we need to improve this figure of 11, where 11 is actually too low. And there are a number of reasons why for that. One is obviously, not trials are available at all centers. We know there's patients' access issues. We know financial toxicities which come with having a diagnosis of oncology. More and more we are doing these trials which are, looking at subtype of glioblastoma or other cancers. So making, criteria has, the restrictive criteria more open will help in enrollment. But on the flip side, we also recognize that glioblastoma is a heterogeneous tumor. And if we have to show or showcase progress, we need to look at particular subtypes or look at gene fusions or other targets, and I'll talk to you some of those. And one of the challenges in our field is new agents often are, just like in oncology, they're always tried in recurrent setting because the bar's lower. You can get a drug approved with a smaller trial in a faster setting, and that's where typically the drug development has worked. And in recurrent setting, and unfortunately in glioblastoma, we've not had that success. So a lot of times these agents are abandoned. So GBM Agile, was an effort which was an adaptive phase 2/3 design, which is enrolling patients both in newly diagnosed setting and recurrent glioblastoma setting. Essentially what it does is it separates out patients who've got MGMT methylated promoter phenotype, and those patients are randomized to a drug, say X, which will be added on to radiation and temozolomide versus radiation and temozolomide, and then the unmethylated arm has radiation plus drug compared to radiation, and then the drug in recurrent glioblastoma is compared to agents like lomustine. Regorafenib was actually the first experimental drug in this trial. We've got a couple of other drugs that have been tested through the mechanisms that include Paxlovid and Val-083. There are other 2 to 3 molecules which are in the process of coming through. One includes VT1021, which is a drug that targets the CD36 and CD47 target. And essentially, what we are trying to do is we are looking at whether we can take advantage of precision medicine in oncology, which is, has been very well showcased in other tumor types, and can we do that in glioblastoma? So there are 2 approaches to this. One is the precision medicine top-down approach, and what it basically means is, say you profile 1,000 patients, okay, and then you figure out what are the pathways which are driving genomically those patients in the tumor type, and then using the next-gen sequencing, whether you're looking at the DNA or you're looking at RNA through transcriptome, you can figure out these pathways, and then you develop clinical assays for prospective clinical trial and look at context of vulnerability and test that. And an example of that was this InSight mechanism, which was headed through Dana-Farber, Patrick Wen, the colleagues, and There were 10 cancer centers around the country which participated in this effort. And here we primarily focused on newly diagnosed unmethylated glioblastoma. And here we know that temozolomide only has limited benefit. It's only actually a 21-day benefit that we get with temozolomide. So here we said, okay, let's skip the temozolomide. So the control arm would be radiation plus temozolomide followed by adjuvant temozolomide. But depending on the genotyping done, which looked at CDK pathways, EGFR pathways, or PI3 kinase pathways, these patients were subdivided into different experimental arms. The good part here basically was that you only had one control arm, because if you do design a randomized trial and you do one-to-one randomization, every time you have a control arm, patients actually don't want to go on a control arm. Although Dr. Brem had alluded a very important point, and that is that patients who go on clinical trials actually do see a survival benefit, whether they are even on the placebo arm. And this is to do with patient modification, it is to do with a more closer follow-up and number of other factors, but anyone who goes on a clinical trial does get a benefit, and there was actually a publication from University of Cincinnati outlining that a few years back. So, but still the focus is that patients actually want to get the drug, they want to get the experimental drug. So this was an effort which looked at progression-free survival, and then if there was an improvement in that, would go into overall survival. And so the MMS-5 arm actually was presented and had some benefit in progression-free survival. CC115 was too toxic, and neratinib was also a tough drug. And so the other approach that you can use is a bottoms-up approach. And here what you do is you see, okay, so let's say hypothetically you treat 50 patients. And we know that when we treat 50 patients with the same drug, generically we'll have some patients who will respond in an amazing manner, and then you'll have patients who will not respond. So just like Dr. Jeyapalan alluded this case where this patient has done so well long term, right? So you would like to know what those patients are, because you want to give them the right drug. No patient wants to get into a drug where they'll not get a benefit. So this approach, on the other hand, looks at a trial, and we did this through ABTC 1402 study that was done through the Hopkins group and the rest of the collaborating centers, and I was involved in this trial because this drug called TRC102 is a base excision repair inhibitor, was founded in the lab of Stan Gerson, who was my cancer center director at Western Case Comprehensive Cancer Center. And essentially what we do know is that, and we've talked about extensively about MGMT, which is a repair mechanism for patients when we give them TMZ. And the other repair pathway is actually base excision repair pathway. And this is a drug that targets that. So Andy Sloan had done this work in orthotopic xenograft models that you can actually see on the right, which is unpublished work. So we took this study of combination of temozolomide and TRC102 in bevacizumab-naive glioblastoma patients in first recurrence. And here patients got a combination. And this was a stage 2 design. It was done through the CTEP mechanism. And we treated first 19 patients. And the goal was that the response rate needs to be increased to 30%. Just to give you a frame of reference with the drugs that we have, the cytotoxic agents like lomustine, our response rates are unfortunately around 5%. Glioblastoma is a very difficult disease to treat, especially in the recurrent setting. And when we looked at overall survival, it was 11 months. Progression-free survival was 2 months. And progression-free survival at 6 months was around 10%, which is very much along the lines of what we see in regular treatment paradigm. However, I personally took care of 2 patients on this study actually who had progression-free survivals of 18 months and 30 months and who had a very nice survival. So we actually collaborated with TGen and Mike Behrens and his group there, and we actually ran the genomic analysis as well as the transcriptome. And based on the transcriptome, we looked at there was a DNA damage response pathway, which the 2 patients who did exceedingly well, and you can see them on the curves on the right, the turquoise curves, they actually had a pathway which could actually designate that these patients were likely to get benefit. There was a 3rd patient who I took care of as well actually on the study who got a borderline benefit, and he was that person with the dotted lines, and he had a borderline signature. The other patients were actually not expected to get benefit based on the DNA damage response pathway. So on the back end, we figured out why some patients did well versus others did not. And this has actually led to a trial that we proposed through SWOG mechanism now, which will look at this in a prospective manner. So we will treat all the patients and validate this biomarker in the prospective manner, whether can this become an integral biomarker if we develop this drug further. So moving on to something that has actually been quite exciting in the last 5 years, and I think will be really exciting in the next 5 to 10 years, and that is gene fusions as potential therapeutic targets in glioblastoma. Because there has been work done by Antonio Averone and his group. There was a paper in Science in 2013, which basically showed that FGFR gene fusions exist in around 3 to 4% of patients with glioblastoma, and that this was found to be true even for the other gliomas. And what we have found is that gene fusions actually are more durable targets. They are actually the driver when they occur, and that's where we've seen bulk of the benefit in glioblastoma. And I'm actually going to go over the NTRK, which occurs in around 1 to 2% of glioblastoma patients, but does occur in 8 to 13% of patients with pilocytic astrocytomas, and it's a very exciting target, and there are a couple of drugs which are FDA approved. So larotrectinib is a drug that was the first drug that was approved for pan-tumor type. It was tumor agnostic drug. That means any patient with cancer who has an NTRK gene fusion can be treated by this drug. It doesn't matter whether they have lung cancer, where NTRK's around 1%, or melanoma, where it's 1%. In polycystic astrocytomas, as I went over, it's around 8 to 13%. And in glioblastoma patients, it's around 1.5% to 2%. So when we looked at those patients who had NTRK gene fusion positive primary CNS tumors, here the overall response rates was around 36%. So this does compare favorably to the 5% or so response rates that we are seeing with alkylating therapies in this patient population. And here you can see 2 out of those 14 patients actually got a complete response, and 3 patients got a partial response, and 9 of the 14 patients actually had stable disease. So this is exciting data. There's another drug called entrectinib, which actually targets not only the NTRK, but it also targets ROS1, which is actually a target that we find mostly in lung cancers. Around 1 to 2% patients with lung cancer have ROS1 alterations. And entrectinib got approved similarly, pan-agnostic, so any cancer patient who has these alterations can get this drug, and it's FDA approved. And here, I'm presenting some work in CNS metastases, and here you can see the response rates are 60% with this drug. So both these drugs are potentially are agents that you can use with patients who have NTRK gene fusions. Next, moving on to other gene fusion targets that can be there, and one of those is actually MET fusions, which actually occur mostly in the secondary glioblastoma patients. And this was a Cell paper that was published a few years back, was a study done in China. And obviously, it was an early trial, 9 patients, and 6 of them were evaluable. And here they showed that 2 patients achieved PR, and 2 patients got stable disease, which is a interesting target, and very similar response rates what we've seen with larotrectinib and NTRK. And there's actually a study going around with APL-101, which is a drug that targets the MET pathway, looking at CNS tumor cohort as well. Next, moving on to some of the other alterations that we see in glioblastoma that occurs, which include the BRAF V600 alterations. This alteration typically occurs in melanoma patients in a greater number. It's around 40 to 50% patients with melanoma actually have these alterations, and these drugs were initially developed for that patient population. And then we also found that these alterations occur in colorectal cancer and are also approved in that patient population. And so this one was a phase 2 trial, basket study of vemurafenib, which is basically a BRAF inhibitor. And you can see response rates of 43% with progression-free survival of around 5.7 months. And then there was a phase 2 trial of dabrafenib and tremetinib. And then there was the ROAD trial where Patrick Wen and colleagues showed very nice response rates north of 50%. Now, you can use just a BRAF inhibitor, but we do know that when you use a BRAF inhibitor in a patient who has a V600 alteration, the primary mechanism of resistance is actually the MEK pathway. Hence, the combination of a BRAF inhibitor and a MEK inhibitor is found to be preferable. And also, surprisingly, when you use the dual combination, you actually see less toxicity compared to when you use one drug. So here we would go over a case, and this is a patient, a 65-year-old female with IDH wild-type glioblastoma who was diagnosed and then was treated with 6 weeks of RT and temozolomide followed by adjuvant temozolomide and TT fields. She was MGMT methylated and an NTRK gene fusion on NGS testing. However, she did have grade 2 thrombocytopenia from prior temozolomide use and did also have a hemorrhage in her glioblastoma tumor. Which treatment would you choose for this patient? Whether would you treat this patient with lomustine, whether you would treat this patient with bevacizumab, or do you think you would use larotrectinib or entrectinib in this patient, or dabrafenib or trametinib? Also, before we go further, you also have additional question on your iPad virtually, and you can actually follow the moment to answer that question with a poll with systemic therapy options for glioblastoma. So moving on to challenges in glioblastoma, and primarily we'll focus on 2 areas. One is the EGFR and immunotherapy, and bulk of my talk is actually going to focus on phase 3 trials, although I'll touch on the phase 2 trials as well. So first, let's start off with the EGFR. We do know that almost 40 to 50% of patients with glioblastoma have some form of genetic alteration in the EGFR pathway. And a number of these have an extra domain truncation that leads to a constitutive activation that occurs in around a quarter of the patients with glioblastoma. It only occurs in the tumor. And hence, EGFR is one of the most well-characterized molecular factors associated with glioblastoma. And we do know that overexpression, amplification, as well as mutation of EGFR to EGFR-V3 are all involved in pathogenesis of glioblastoma and has been subject to multiple targeted therapies in glioblastoma. And what we have seen, unfortunately, we have treated these patients with drugs like gefitinib or erlotinib, which are tyrosine kinase small molecule inhibitors, first generation. We use drugs like cetuximab, which are monoclonal antibodies, or nimotuzumab, which is again a monoclonal antibody. And the trials with all of these were unfortunately negative. Then there was a vaccine called rendopipimid, which targeted the EGFR-V3 variant, and we were very excited based on some of the initial work from the group at Duke when we compared it to the historical controls. However, the phase 3 randomized open-label trial in newly diagnosed glioblastoma were all negative. Then recently, this trial was completed through the NRG mechanism and was presented at SNO and had a follow-up publication in Neuro-Oncology, a study led by Andy Lassman and colleagues. And basically, this was looking at dabigatran or dabigatran madoffin. And basically, what it is it's actually an antibody-drug conjugate. And here, what we are trying to do is we are combining a monoclonal antibody that binds to an activated EGFR wild type and the V3 mutant linked to a microtubule inhibitor toxin. So essentially what we are doing is we are using a Trojan horse approach. So the EGFR pathway, we are not directly targeting it. We are actually using it to transverse inside the cell. And there, the microtubule inhibitor toxin actually gets released. And the phase 2 trial in recurrent setting actually had shown some hint of efficacy, but the randomized phase 3 trial that was done in the upfront setting unfortunately did not show any survival benefit. So again, added to a line of trials which have failed to show therapy benefit. But there is a number of studies which are looking at the EGFR targeted therapies in glioblastoma, and you can see a number of ongoing trials which are looking at different ongoing efforts, which include the D2C CED approach, where they are using a single chain monoclonal antibody, fragment immunotoxin. It also targets the EGFR-V3. They are looking at nanotechnology-based efforts. There is a lot of interest about CAR T cells targeting the anti-EGFR-V3. We know that approach is being used in other tumor types as well. There is interest in BiTEs, which are bispecific T cell engagers. One challenge in glioblastoma with the BiTE-based approach is that it's a very immunosuppressive tumor. So as a result, you have a lot of Tregs, which are upregulated, but your T cells, which you need, the good T cells, are not that much because of the immunosuppressive environment. And hence, some of the biospecifics have struggled. You can also look at BATs, which are bi-armed activated T cells. Camilo Faggiola and his group at UVA is looking at a number of approaches targeting that, especially in the HER pathway. And then we have newer ADCs, which are said to be more potent, maybe less toxic than the prior approaches. And then there are efforts looking at intraarterial infusion of drugs like cetuximab. Then moving on, as you know, in the last decade or two, there's been a lot of interest in immunotherapy, and which has been really been transformative for a number of other cancers. For example, lung cancer, stage 4 lung cancer, the survivals was around 5% to 10% a decade back. And now we know a stage 4 lung cancer patients, average survival is around 20 to 25%, and most of this has been driven by immunotherapy-based approaches. However, in general, the neuro-oncology community has not enjoyed the groundbreaking studies and observations that have been seen in other types of cancer. With the exception, the rare subtype of patients with glioblastoma whose tumors have a signature hypermutation burden because of a germline biallelic mismatch repair deficiency, and that can derive benefit from immune checkpoint inhibition. And there was a very nice JCO paper by Eric Buffet and his colleagues from University of Toronto showing these two cases where they saw remarkable benefit with immune checkpoint inhibition. And some of our other efforts where we have looked at mismatch repair deficiency that arises after challenge from temozolomide, we have not seen the benefit with anti-PD-1 based approaches. So next couple of minutes, I'm going to talk about 3 large phase 3 trials that were done using an anti-PD-1 drug called nivolumab. First one was the Checkmate 143 study, which was in recurrent glioblastoma. Second is the Checkmate 498 study, which was a phase 3 randomized trial of RT plus nivolumab. This was an unmethylated population, so we got rid of temozolomide in the experimental arm, but we used the temozolomide and radiation in the control arm. And then final was the Checkmate 548 study. This was a phase 3 trial. Here, nivolumab was added to temozolomide and RT in methylated MGMT patients. And so first trial was the Checkmate 143. This was where we compared nivolumab to bevacizumab. And here you can see overlapping curves again. And both the drugs with patients in first recurrence had a median overall survival of around 10 months. If you remember the EORTC trial of Wolfgang Wig, the benefit with bevacizumab plus lomustine in that trial was around 9 months. So patients in first recurrence of glioblastoma, typically when they're treated on any therapies, their benefit is around 9 to 10 months, and that's what we saw with this patient population with nivolumab. Next was the Checkmate 498 study. This was radiation plus nivolumab, and here as well you can see, unfortunately, there was no benefit seen with the nivolumab compared to temozolomide. In fact, temozolomide, you can see the curves are slightly better, although the hazard ratio was 1.31, basically, so patients who actually got radiation and temozolomide did better even in the unmethylated setting. And so hence, if you have a patient who's unmethylated MGMT, it's very reasonable to still give them temozolomide if you don't have a clinical trial. Then the final one was Checkmate 548 study. Here, nivolumab was combined with radiation and temozolomide compared to placebo plus radiation and temozolomide. And here as well, you can see, unfortunately, there was no survival benefit with adding nivolumab plus RT compared to, and temozolomide compared to placebo. But what is interesting to see on these trials is that you see the median survivals are increasing. So this highlights the point that Dr. Jeyapalan had made that, although it's a difficult to treat tumor, but if you look at trials that were done 2 decades back compared to trials that you are seeing now, the survival window has moved. Yes, sometimes the eligibility criteria is a little bit more restrictive these days, especially when it comes to steroid requirements in trials like these. But I also think there has been improvement in surgery. So Dr. Brem and his colleagues can use techniques now where they can remove the tumor more without harming the patient. We have better therapies, and more importantly, we are able to take care of our patients better when they have toxicity. So I think all of this combined has helped our patients further. So what are some of the challenges of immune checkpoint inhibition in glioblastoma? I think one of the challenges is that glioblastoma is really a very immunosuppressive tumor, and it is actually a cold tumor. We have this concept of hot tumor and cold tumors. So if the tumors are hot, which are like melanoma, immunotherapy works really well. If a tumor is inherently cold, like a glioblastoma or prostate cancer, the chances of immunotherapy working is less. And in glioblastoma on top, it's a very immunosuppressive tumor where the CTLA4 is upregulated, and overall, the Tregs are much higher, and the good T cells are less, and overall CD4 counts are lower. So Skip Grossman and colleagues have showed that these patients tend to live less. And on top, a lot of T cells which should be in the tumor are sequestrated into the bone marrow, as work from Peter Fetchy and his group from Duke. So we actually led a study out of Cleveland Clinic where we said, okay, a lot of our patients in recurrent glioblastoma are on steroids. Can we mitigate the need for steroids? Can we use bevacizumab, which is a steroid-sparing agent, and we can use 2 doses of bev because there was work out of Rakesh Jain's lab showing that maybe low-dose bev may less cause a mesenchymal phenotype EMT conversion. So we looked at 2 different doses of bev. What we found was that the progression-free survival and overall survival with both these arms was comparable to each other and not different compared to what we had seen with the historical controls. However, I will showcase some data tomorrow where patients over 60 made some benefit with a standard dose of bev. Next, moving on to, there's a lot of interest in neoadjuvant delivery of anti-PD-1, and we have seen that to happen in a number of tumor types. We do that in breast all the time. We do that in head and neck cancer. So this was an effort led by Tim Clausey and colleagues, and they actually used, they treated half the patients with anti-PD-1 approach post-surgery, and half actually got it prior to surgery. And here you can see they did show some benefit in efficacy in a small trial with the neoadjuvant approach, and this is an area of active interest in recurrent glioblastoma right now, but we do know that we may need a combinatorial approach rather than just using anti-PD-1. So what can you do? Well, you can combine it with other agents. So there is data out there that the tumor treating fields may have a mechanism where it can augment immunotherapy. So there are these trials to the top study, which basically was using tumor treating fields and temozolomide with pembrolizumab and used to control it and compare it to historical controls of TT fields and temozolomide in a small group of 25 patients. This data was presented at SNO last year. We did see a benefit, and then more recently, data was actually presented in Korea showing that there may be a benefit of even greater than 2 years. So early data, small number of patients, but the approach looks promising and should be explored further. One other study that I would like to highlight is an effort with my colleague here, Steve Brem has been involved. Steve Bagley out of University of Pennsylvania has been leading this study out of the NRG mechanism. And as I said, that anti-PD-1 alone probably is not a very good strategy for us. So how can we make it better? We can combine it with other therapies, just like we can use dual immune checkpoint blockade. And one of that is using IL-6 with tocilizumab and then combining with the atezolizumab, which targets the anti-PD-L1 pathway. So this is a trial which has a safety run-in, then there is a phase 2 surgical cohort, and then there's a phase 2 non-surgical cohort, and you have a fairly complex design. But what we are trying to do with these window of opportunity trials is that we're trying to see, can we give the therapy and what is the effect of that on the tumor? And you saw that with the neoadjuvant study also that Dr. Clausey was approached with. With that, obviously, there is a lot of interest in a trial that will be presented here on Sunday, and Dr. Steve Brem is involved in that effort, so I'll pass on the mic to him to talk about this exciting trial that he's been involved for a long time and give you a preview of what you might hear on Sunday. So thank you so much for your kind attention.
Thank you. It's great. That was a tour de force. Dr. Jeyapalan spoke about a 4-minute mile. I think you just did probably the fastest man on earth. You just gave it like a 2-day symposium in that brief time. So I just want to restrain my enthusiasm for a minute and tell you this is one of the most exciting times in my career as a neurosurgical oncologist to preview a study that was published this morning. So that you guys are really among the first presentation to formally present this work. And it's something that has been, we've worked on as a brain tumor community for 15 years. And can I have the next slide, please? Or I control that, okay. The principal investigator is Linda Liao, and so what we wanted to do is just give a teaser today. You remember when we had movies, movie theaters, there would be like previews. So the audience here today is like a test group preview for Sunday morning at 8:20 a.m. It is CTIM, Clinical Trials Immunology 27, and Dr. Linda Liao, who did the original work in her laboratory and is the PI on this study, will present that work. Just to give you a perspective, There have been 400 clinical trials that have failed. I think I've been involved in about 100. If I was trying for Philadelphia Phillies, a hitter with a batting average of 1%, I probably wouldn't make the team. We haven't done that great. Well, this one, first one that in the last 30 years goes back to work my brother Henry Brem did with gliadel wafers, and that received FDA approvals. Temozolomide with Roger Stoop, and tumor treating fields, which has been very nicely presented at this meeting. So what is a fourth modality? This was, again, from this morning with Linda Liao. Kimur Ashkan, who's at this meeting, presented at the British SNO and is a leader in Europe. There are 4 countries, over 70 authors on the full study, and also wanted to mention Marnix Bosch is the senior corresponding author who's contributed a great deal in terms of the overall management and direction of this trial. So many people, probably some in the room, have been involved with the dendritic cell vaccine. This is the top line, sort of the headlines of this. Phase 3 non-randomized controlled trial, 331 patients received vaccine either newly diagnosed or recurrent setting. In patients with newly diagnosed glioblastoma, we are reporting that improves the overall survival compared to contemporaneous matched external control patients. The trial itself, in terms of design, is innovative, using synthetic external contemporaneous controls. For patients with recurrent glioblastoma, the median overall survival was prolonged by several months from relapse in the vaccine group compared to the external control cohort. We saw meaningful increases in long-term tail of the survival curves in patients with newly diagnosed and recurrent diseases. As Dr. Liao has emphasized, patients in the clinic are less concerned with statistical analysis of significance and marginal benefit, but they want to be in that long-term survivor over 5 years, and there is a significant tail in this trial. Survival was increased in all the subgroup analyses, but was especially pronounced in those over 65, those MGMT methylated, and significant residual disease. So it was a bit surprising the elderly patients actually did well. And as a surgeon, significant residual disease, meaning up to 2 centimeters. The vaccine is well tolerated, as most of the immunotherapies are, and was not associated with a cytokine release storm or autoimmune reactions, and there were very rare adverse events. We don't have time to go into all of this, but it is online, and I invite you to see the abstract Sunday presented by Dr. Liao. Thank you very much, and now we can take some questions from the audience. Some of the, what are the dose-limiting toxicities of the device, Dr.
Yeah,
Sarai?
so there really wasn't a DLT, so the 50% of the patients had a grade 1 to grade 2 skin toxicity, which from Mario Lepoutra's paper is now easily managed. And then for 2% had a grade 3, so nobody really had a DLT with the device. It's actually an incredibly well tolerated and a device that's very safe.
That's good, thank you. Next question would be, what is the threshold for stopping tumor treating fields in poorly compliant patients? I think that begs the question, if the patient's poorly compliant, you're probably not going to continue.
Yeah, I'm not sure, is the mic on? Can people hear me? You can hear me, okay, great. I'm sorry, now I think I can. I'm sorry, could you repeat that again? That was the...
When do you stop tumor treating fields in poorly compliant patients?
Right.
We probably don't start.
Yeah, I tell patients if it's clear that if they're not going to be using it 12 hours or not, I tell them, and we can't convince them, we just stop using it, and I tell that to them. And we have a couple of patients that are like that, and they understand, and they just stop using it.
So we have, so here's a question I'm going to give to my colleague, Dr. Manwi Ahluwalia, who is Deputy Director for Miami Cancer Institute. I failed to mention that, and Chief of Medical Oncology and Chief Scientific Officer at the Miami Cancer Institute. So here's an open-ended question for you. You have a patient with recurrent glioblastoma. Many trials are open. How do you choose among them which is the right one for the right patient?
Sure, yeah. So it's, first of all, you hope you're at a center where you have multiple trials open.
Yeah.
Second is, is the patient in first recurrence or second recurrence? And as you know, that most of the large randomized trials are primarily being done in first recurrence. So there are both advantages of going to a randomized trial, because that means that the drug is probably going for an approval, so it has more history behind it. The challenging part of that is it's a flip of a coin often because it's one-to-one randomization. So sometimes that will be a decider for some patients. Some patients want to absolutely say, this trial is randomized, so I have 50% chance going on it, and this trial I will go on the experimental agent. So if the drug or the modality is exciting, I think they like to go on the experimental therapy where they have a full chance. I would say in the last 5 to 8 years, there was significant interest in immunotherapy. So people would not only come to us, they would say, oh, do you have an immunotherapy trial? So we saw a ton of patients doing that. Unfortunately, as what we have seen data so far, that at least the anti-PD-1s by themselves with the caveat of neoadjuvant approach is not going to be the case. So the question is, can you have a dual immunotherapy effort for them? Or do you have these, you went over the dendritic cell vaccine approach, those are exciting. Or you have some of these genetically engineered viruses. We did not cover a lot of data behind that. But what we've seen with the genetically engineered virus too, most of the efforts have shown that 20% of our patients get benefit. The challenge for us is that we have not been able to pick a biomarker. What we all know is that if someone's tumor mutational burden is low, they're going to get benefit from that, as has been shown by the Duke group. But what we do know is that if your tumor mutational burden is low, typically those patients do well. So I think that's more of a prognostic marker, frankly, rather than a predictive marker. So a lot of times it will also depend, is patient, how much of a tumor they have behind, whether they are on steroids or not. So if someone has a large tumor which is still behind, or they are still on a significant dose of steroids, they typically don't do well on immunotherapy trials or typically are excluded from those trials. I personally, in the last few years, am convinced that if we're going to see some benefit in this tumor type, it will come in gene fusions. I'm very excited about that approach. So there is the MET gene fusion drug trial with the APL-101 that I talked about. There is another study looking at FGFR pemigatinib study that actually we have a poster tomorrow, which I think is interesting avenue. And then there are drugs which target the NTRK gene fusion. The challenge for us is FGFR gene fusions are only around 3 to 4%, NTRK's 1%, and MET-PTZ is rare and mostly occurs in secondary glioblastoma. So it's a very small subtype. At least small molecule inhibitors with EGFR, not too exciting right now. I'm still excited about some CAR T-cell therapy work, and you have Donna Rook at your place looking at combinatorial approaches there, which I think are exciting. But to give a long-winded answer, I think it's patient-specific. But every time I have this discussion, I actually have a patient as an active participant. I think as a physician, our jobs is to tell them the information which they can understand at that level and help them make that decision.
That was a very comprehensive answer, and I appreciate it. I'll also just reinforce some of the points Dr. Ahluwalia made. What is missing in the field is rapid, interactive, specific, sensitive, clinically relevant biomarker. This has greatly spurred other fields. For example, 1 million Americans died of COVID, but it's still out there. A few people are dying because we have rapid antigen tests, we have PCR. We pretty much conquered HIV and made it controllable because we can test viral load. We can see if a regimen is working, and we can stop it if it's not working and start something that's effective. We don't have that yet in neuro-oncology. This trial that I mentioned that I'm super excited about is actually took 15 years, hundreds of millions of dollars, and you know, and now we're getting the Kaplan-Meier curves and so on, but it's still, I'm looking for the next generation of immuno-oncology to be, and tumor treating fields to be one that we can adjust to the patient and get an answer right away, which is what the patients want. And along those lines, on Sunday also, there are 4, thank you for mentioning, University of Pennsylvania has 4 presentations on biomarkers, and Dr. Christos Davasikos, his group, has 10 abstracts here and has formed a very large consortium, the RESPOND consortium, using AI, machine learning, and so on, to take a very extensive database, hundreds of patients with glioblastoma, get a normative survival, predict where the tumors kind of come back, and we think we'll be using this soon for some of your trials. And Dr. Suyash Mohan has devoted his career to developing multimodal MRI, and he published the Red Journal. He's part of that article. Thank you for including that with Roger Stoop to show that there's a dose response in tumor treating fields, that the recurrences are out of field, and that's what we need to make skeptics believers in these technologies and widely adopt these new technologies because you need to see how they're working in individual patients. So it's an important question, and thank you for your answers. How do you decide on timing of surgery? Well, usually a newly diagnosed glioblastoma, of course, will be urgent, and as soon as the patient is prepared, we schedule surgery. For recurrence, it's a little bit more nuanced. It depends if the patient's having symptoms. If we think it's, again, we don't have all the tools in place, but if it's progression and it's surgically accessible, so we make that calculation. We are always trying to minimize injuries, so it depends on location. We're using tools that you mentioned. Think surgery is safer while being more radical, more effective, using diffusion tractography and now connectome analyses. So we're trying to do smarter surgeries, just like smarter clinical trials. So I think that's what would is interstitial radiation an option in treatment of glioblastoma? Do either of you want to take that on?
I've personally not had any much
Yeah.
of experience in that field.
There is the gamma tile trial. Yeah, this is very attractive because local recurrence and radiation is helpful. I was part of the GliaSite, which is a balloon and trial with, it was the problems are it's a yin and yang of balancing risk with benefit, and the risk is of radiation necrosis, which can also cause swelling. So that trial is still ongoing, and
Steve, I was wondering if I could, there was a first question that
sure.
just came up.
Why don't you take that?
So there's one that says, is there a time limit for use of tumor treating meters, and for how long can people continue to use it? And I alluded to this in my my case presentation about the 80-year-old woman. So you can learn from your successes as well as your failures. So Tufts participated in the EF14 trial. They put 17 patients on the trial, 10 got the device, 7 got standard of care. And the first person that enrolled was in 2010. He drove down from Montreal, and because they didn't have the trial open in Canada, and he enrolled into the trial. And 12 years later, and the Canadian government, only paid for Temodar for 2 years. They said that there's no role for it after that. And 12 years later, he is still alive. So he's been doing 10 years of Optune monotherapy, essentially. And he's had 2 recurrences. The first one was taken out in 2016, and the surgeons took it out. And then he had a more recent recurrence now again. And so now they're adding on temozolomide again onto him. But one of the things to realize is that solid tumors are always trying to come back. And we had a little discussion with Steve. The tumors that we're curing are really the liquid tumors, right? The lymphomas, the leukemias, because we can do a bone marrow transplant and get rid of, say, every single nidus of disease. We can't do that with solid tumors, right? Dr. Brem, although he's an excellent neurosurgeon, can't do brain transplant yet. And as I tease my patients, you wouldn't want that because it wouldn't be you anymore, right? It would be somebody else, and unless somebody's giving you a better body, I wouldn't sign up for that surgery. So we have to have a treatment that can chronically suppress the disease from coming back that is well tolerated. And tumor treating fields definitely are well tolerated. People can use it till the cows come home, if you know. And it can prevent these niduses of disease from coming back. So I told people the paradigm is changing for solid tumors, right? We're not curing their solid tumors, we're treating it. We don't cure people's hypertension, we treat their hypertension. We don't cure people's diabetes, we treat their diabetes. Or we're not curing solid tumors, we're treating it. And we need, treatments that can be tolerated. And unfortunately, I can't keep giving chemo, it's not tolerated. Dr. Brem can't continue giving surgery because they have, wound breakdown. And Dr. Ahluwalia can't keep giving radiation because of radiation necrosis. But the treatments like tumor treating fields, immunotherapy, targeted therapy, these ones can be given chronically, and I think that's going to be the wave of the future.
Just a very quick question, yes or no, because we're just at the end of our session. Would you recommend tumor treating fields for a grade 4 WHO IDH mutant positive legacy GBM?
The legacy GBM. So these trials were all done before the recent, the 2016. Yes. So when they did a post-hoc analysis on people that had still analyzable tissue, and it was about 50% of patients in the EF14 trial, it was matched between the two, about 5%, 6% in each group had IDH mutated. And they haven't done a post-hoc analysis to take a look specifically, but the Canadian patient I just told you about, he was IDH mutated, so there's that. So I think, being MGMT methylated, being IDH mutated, these are all things that predispose one to have good response to treatment. And I think it definitely helps.
So thank you. Thanks to the speakers, and thank you so much. There's just 3 points as we conclude this housekeeping. Please visit the website peerreview.com/2022 capital GBM. You must complete and submit your post-test evaluation to receive CME credit. You can download the slides and all the practices. There are a lot of things like NCCN guidelines, and so there should be a treasure trove there. And watch the replay of this event if you miss parts or others in your team in the next 24 hours, and also there will be online activity in the coming weeks. So thanks very much for coming, and thanks again.